Common mental health issues. This is trauma and stressor-related disorders, as well as substance use related and addictive disorders. As I've said in other PowerPoints, all of the technical information in this PowerPoint comes from the Diagnostic and Statistical Manual of Mental Disorder as published by the American Psychiatric Association. I have added my own commentary as it relates to this course. I have highlighted several of the most commonly diagnosed mental health issues that may present in your clinic, office, classroom, or other place of work, and it will vary depending upon the population that you encounter. Please keep in mind that as I go through this PowerPoint, that the DSM is a categorical way to look at mental health issues. It is included here so that if and when a client or patient comes into your office or clinic or practice and states they've been given a diagnosis of a certain disorder, you have at least a rudimentary idea of what they mean. I am totally on the side of depathologizing and destigmatizing mental health issues, and I encourage all of you to seek to find ways that maybe figuring out what's driving a behavior that has been categorized or compartmentalized into a set of criteria. Expressed behavior that fits a diagnosis can be looked at as an adaptation to experiences or life events that may have felt overwhelming, chaotic, and sometimes could even rise to the level of life-threatening. Learning about these definitions, diagnosis, and criteria is important, but always keep in mind that you are working with a person that may have had to learn ways to cope in less than ideal circumstances. I ask that above all, you stay curious about the person, not the condition. Starting out first of all with trauma and stressor-related disorders. This includes disorders in which exposure to a traumatic or stressful event is listed explicitly as a diagnostic criteria. Psychological distress following exposure to a traumatic or stressful event is quite variable, and in some cases symptoms can be well understood with an anxiety or fear-based context. I'll be discussing these in more details in Module 4, Trauma and Addiction. We'll start with reactive attachment disorder. Now, this is a diagnostic feature that includes disturbed and developmentally inappropriate attachment behaviors in which a child rarely or minimally turns preferentially to an attachment figure for comfort, support, protection, and nurturance. When distressed children with this disorder do not respond more than minimally to comforting efforts of caregivers, they may display diminished or absent expressions of positive emotions during routine interactions with those caregivers. So some clinical features of this disorder has been found in young children exposed to severe neglect before being placed in foster homes and or raised in institutions. So with development in course, social neglect is often present for the first months of a child's life. Environmentally, social neglect is the hallmark diagnostic requirement for this disorder. Some of you may remember some cases of children being adopted from orphanages in Russia. And there's been some documentaries and things that have been done about that I highly recommend if you're interested in this. There's on Netflix. It's called The Dark Matter of Love. It's really quite good. All right, so diminished social engagement disorder is a hallmark of this behavior is that it involves culturally inappropriate, overly familiar behavior with relative strangers, with behavior that violates social boundaries. Development in course, conditions of social neglect are often present in the first months of a child's life diagnosed with disinhibited social engagement disorder. Indiscriminate social behavior, there's a lack of reticence with unfamiliar adults, and toddlerhood is often accompanied by attention-seeking behaviors, as well as with preschoolers. Clinical features in middle childhood manifest as verbal and physical unfamiliarity, as well as inauthentic expressions of emotions. Post-traumatic stress disorder. Development of this disorder includes exposure to one or more traumatic events. The clinical presentation of PTSD varies, and in some individuals there is a fear-based re-experiencing, emotional and behavioral symptoms that may predominate. In others, anhedonic or the ability to feel pleasure, or dysphoric, which are intense feelings of depression and negative cognitions, may be the most distressing. Other individuals display arousal and reactive externalizing symptoms, while still others display dissociative symptoms predominantly. Other individuals may exhibit a combination of these symptom patterns. Associated features may include developmental regression, including loss of language in younger children. There can be auditory pseudo-hallucinations may be experienced, as well as paranoid ideation. With prolonged, repeated, and severe traumatic events, individuals may experience difficulty in regulating emotions or maintaining stable interpersonal relationships and experience dissociative symptoms. Development in course, PTSD can occur at any age, with symptoms usually beginning within 3 months following the traumatic event, although there may be a delay of months or even years before criteria for the diagnosis is met. This may be termed delayed onset or delayed expression. Frequently, individuals meet the criteria for acute stress in the immediate aftermath of a trauma, so the diagnosis of PTSD differentiated from acute stress disorder, the differentiation is time. Some individuals remain symptomatic for longer than 12 months and sometimes for more than 50 years. Symptomatic recurrence and intensification may occur in response to reminders of the original trauma, ongoing life stressors, a newly experienced dramatic event. There may be declining health, worsening conditions, and social isolation, which may exacerbate the PTSD symptoms. There is an association of frightening dreams with content specific to the traumatic event. Events happening before the age of 6 years, often younger children will display symptoms through play that refer directly or symbolically to the trauma. Parents may report a wide range of emotional or behavioral changes in young children who may display image interventions in their play or storytelling. Children may display the behavior that is associated with restrictive or exploratory behavior beyond their age, and there's reduced participation in activities in school-age children or reluctance to pursue developmentally appropriate opportunities in adolescence. Adolescents may harbor feelings of being changed in ways that make them socially undesirable and estrange themselves from their peers. Irritable and aggressive behavior is sometimes common and can interfere with peer relationships and school behavior. Reckless displays of behavior may lead to accidental injuries to self or others, and there can also be displays of thrill-seeking or high-risk behaviors. So with risk and prognostic factors temperamentally, environmentally, this can include problematic emotional behavior in childhood prior to there can be prior mental disorders, exposure to prior trauma, child adversity, and family psychiatric history. Other environmental factors can be severity of trauma, perceived life threat, personal injury, interpersonal violence, witnessing atrocities in military personnel, including being a perpetrator or killing the enemy. There are often negative appraisals, inappropriate coping strategies, subsequent exposure to repeated upsetting reminders, subsequent adverse life events, financial and other trauma-related losses, and there can be an increase in the likelihood of developing this disorder. As far as culture goes, severity and onset of PTSD may differ across cultural groups as a result of variation in the type of traumatic exposure, the impact on disorder severity, and the meaning attributed to the traumatic event. The ongoing sociocultural contexts and other cultural factors may make it detrimental. Clinical expressions of the symptoms or symptom clusters of PTSD may vary culturally, particularly worse with respect to avoidance and numbing symptoms, distressing dreams, and somatic symptoms. Functionality, there is an associated high level of social, occupational, and physical disability, as well as considerable economic cost and high level of medical utilization. Impaired functionality is exhibited across social, interpersonal, developmental, educational, physical health, and occupational domains. There is an increased risk of suicide within this population. There is also high levels of comorbid substance use disorder and conduct disorders. Young children with PTSD have at least one other diagnosis. The pattern of core morbidity are different than in adults, with oppositional defiant disorder and separation anxiety disorder predominating. Acute stress disorder and adjustment disorder. So features are similar to PTSD. The difference is in the parameters of time. Characteristic symptoms associated with acute stress disorder last, by definition, anywhere between 3 days and 1 month. Exposure to one or more traumatic events is, of course, a hallmark. The clinical presentation of acute stress disorder varies by individual, but typically involves an anxiety response. There may be dissociative or detached presentations, although these individuals typically will display strong emotional or physiologic reactivity in response to trauma reminders. Witnessed events include, but are not limited to, observing threatened or serious injury, unnatural death, physical or sexual violence inflicted on another individual as a result of a violent sexual assault, or other kind of assault, severe domestic violence, severe accident, war, and disaster. It can also include witnessing a medical catastrophe, especially traumatic if this includes one's child. So some associated features involve those witnesses, people that witness and survive trauma inflicted upon another oftentimes will experience excessive amounts of guilt related to surviving or not having prevented the traumatic event from happening. Individuals with acute stress disorder will exhibit symptoms similar to those of PTSD, including but not limited to recurrent, involuntary, or intrusive distressing memories, distressing dreams, dissociative reactions, for example, in the form of flashbacks, intense or prolonged psychological distress, negative mood, avoidance symptoms such as efforts to avoid distressing memories, thoughts, or feelings, and an effort to avoid external reminders in the way of people, places, conversations, activities, or situations. They may also exhibit arousal symptoms associated with disturbed sleep, irritable behavior, or angry outbursts, hypervigilance, difficulty concentrating, and even an exaggerated startle response. Development in course. So with acute stress disorder, it cannot be diagnosed until 3 days after a traumatic event. It may be a transient stress response that remits within 1 month after the trauma exposure, not resulting in PTSD. So risk and prognostic factors. Temperamentally, people with acute stress disorder have high levels of negative affect, greater perceived severity of the traumatic event, and may engage in avoidant coping mechanisms. Environmentally, individuals exposed to a traumatic event are at high risk for acute stress disorder and are at higher risk of having with a prior history of trauma. Culture and gender symptoms of acute stress disorder vary, particularly with respect to dissociative symptoms, nightmares, avoidance, and somatic symptoms. So gender-related diagnosis is shown in the DSM-5 to be more prevalent among female identifying patients. They go on to state that an increased risk for the disorder is female identifying and may be attributed to a greater likelihood of exposure to traumatic events with higher conditional risk for acute stress disorder. Functionality. There can be social, interpersonal, or occupational domains affected by acute stress disorder due to high levels of anxiety that may manifest with sleep, energy levels, and capacities to concentrate and attend to the tasks at hand. Avoidance reactions may result in a withdrawal from situations that are perceived to be potentially threatening, which may lead to absenteeism from work or missed appointments that may be related to or about the traumatic event. Adjustment disorder. So there are emotional behavioral symptoms as a diagnostic feature of adjustment disorder. The precipitating stressor may be a single event or multiple stressors. Recurrent stressors that are associated with seasonal business crisis and may affect a single individual, an entire family, or a large group or community. Adjustment disorders may be diagnosed following the death of a loved one, when the intensity, quality, or persistence of grief reactions exceeds what is normally to be expected. A differential diagnosis of persistent complex bereavement disorder may be necessary in this situation. Something to remember is that adjustment disorder can sometimes be seen as a catch-all diagnosis. Development and course. Disturbances by definition begin within 3 months of the onset of a stressor and last no longer than 6 months after the stressor or its consequences have ceased. Cultural settings should be taken into account in making a clinical judgment about an individual's response to a stressor, whether it is considered to be maladaptive or in excess of what would commonly be expected. It is important to carefully consider meaning and experience of the stressor as well as an evaluation of the response. Functionality. So a hallmark criteria is often manifested as a decreased performance at work, school, or temporary changes in social relationships. Adjustment disorders may complicate the course of illnesses. An individual who has like general medical conditions, adjustment disorders may accompany other mental disorders or medical conditions, but only if the latter does not explain the particular symptom that occurs in reaction to the stressor. There may be an associated depressed mood or symptoms associated with obsessive compulsive disorder. Substance-related and addictive disorders. So this is a cluster of cognitive, behavioral, and physiologic symptoms indicating that the individual continues to use the substance or the pattern of behavior despite significant related problems. An important characteristic of substance use disorder is an underlying change in brain circuits that may persist beyond detoxification, particularly in individuals with severe disorder. These effects of any brain changes may be exhibited in the behavioral consequence of repeated relapse and intense craving. The disorders occur in a broad range of severity from mild to severe, with severity based on the number of symptom criteria. The general categorization include mild substance use disorder, which is suggested by the presence of 2 to 3 symptoms, moderate by 4 to 5 symptoms, and severe by 6 or more symptoms. There are course specifiers and descriptive features. Specifiers include early remission, in sustained remission, maintenance therapy, and in a controlled environment. I'll discuss these issues more detail in Module 4, Trauma and Addiction. So with substance use and substance-induced disorders, the categorization of substance-induced disorders include intoxication, withdrawal, and other substance or medication-induced mental disorders. The DSM-5 states that substance-related disorders encompass 10 separate classes of drugs: alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics, anxiolytics. Stimulants include amphetamine-type substances, cocaine and other stimulants, tobacco, and other known substances. It's important to remember that these 10 classes are not fully distinct and that all drugs taken in excess have a common direct activation of the brain reward system, which is often involved in the reinforcement of behavior. Some things to take into consideration are things like rate of admission, speed of effect, and duration of effect. Routes of administration produce more rapid and efficient absorption into the bloodstream. For example, intravenous, smoking, intranasal, and snorting. So there tends to be a result in a more intense intoxication and an increased likelihood of escalating pattern of substance use leading to withdrawal. Rapidly acting substances are more likely to produce immediate intoxication. Relatively short-acting substances tend to have higher potential for development of withdrawal than do those with longer duration of action. However, longer-lasting substances tend to have longer withdrawal duration. There are laboratory findings like analysis of blood, urine samples. Those can help to determine recent use and the specific substances involved. However, a positive laboratory test is not in and of itself indicate that the individual has a substance use disorder or substance-induced disorder. The development and course. Individuals between the ages of 18 and 24 have a relatively high prevalence rate for the use of virtually every substance, with initial substance-related disorders most likely beginning in the teenage years. Now, when we talk about process addictions, it is important to remember that addiction is not isolated to substances. Addiction can include what are known as process addictions or non-substance related disorders such as gambling, shopping, and behaviors related to sex, acting alone, or acting out with others. So some general definitions of addiction. Common criteria across all potential addiction disorder related diagnosis is that persistent, recurrent, problematic behavior. It leads to clinically significant impairment or distress, as is indicated by the individual exhibiting multiple behaviors over a 1 to 2 year period of time. There is often an increased amount of substance needed or contact, as when with process addictions. In the case of gambling, it would be more money. In the case of shopping, it would be shopping. In the case of a sex-related addiction, it would be in contact with the contact of choice, whether that be pornography, whether that be in person, whether that be, there's multiple different ways that gets acted out. There is often a sense of restlessness or irritability when attempting to cut down or eliminate the behavior. There is often repeated unsuccessful efforts to control, cut back, or eliminate the behavior. There is often preoccupation with substance or the process. The person may use the substance or engage in the behavior when they are feeling stressed or distressed, such as helpless, guilty, anxious, or depressed. When we talk about functionality, people often lie to conceal the extent of their use or involvement or engagement in the behavior, and they may have jeopardized or lost a significant relationship, a job, or educational or career opportunities because of their related behavior. These behaviors are not better explained by a manic episode, as is criteria in bipolar I disorder.